We are live now.
Shall I go ahead and start?
Yes, please.
Great. So my name is Miriam Jorgensen. I'm research director at the Native Nations Institute at the University of Arizona. The University of Arizona is on the homelands of the Ta'antem and Pasquayaqui peoples. And in the state of Arizona, we share geography with 22 tribes within the state. I just want to acknowledge them and their elders and their leaders before getting going. I'm presenting today with Dr. Kiera Ladner, and I'll let her introduce herself before we get going on our presentation, which is a shared presentation just during the first bit of this on impacts, COVID-19 impacts on Indigenous persons in Canada and the US.
Thank you, Miriam. I'm Kiera Ladner. I teach at the University of Manitoba, as Miriam said, which is on Treaty 1 territory on the homeland of the Métis. And I just want to pay respect to the elders and the knowledge keepers of the communities and the peoples whose lands that I sit on here and wherever you sit while listening. And we'll just begin with that. Thank you, Miriam. And we're going to switch back and forth, and hopefully we'll make a seamless presentation.
So as I mentioned, we're actually going to do this combined presentation, and that's why Kiera said we're going to be switching back and forth. We've been involved, as many of the folks attending the Metropolis conference know, in a process of surveying populations of special interest in the US, Canada, and in Mexico, with oversampling essentially of people of color, of newcomers, and critically of Indigenous populations. So each of these countries in North America, in the nation states that are now Canada, the United States, and Mexico, have, of course, significant Indigenous populations. And one of the things that we know about COVID-19 is that it has had a disproportionate effect on Indigenous peoples. So the survey process that we've been involved in, of which we have data so far from 2 waves of the survey, really tries to help us narrow in on understanding how these populations have suffered similarly and have experienced resilience similarly, and what some of the critical differences in between these populations are, between these populations in the mainstream, between each other, and then differences within these communities as well. So we're going to try to dive into a little bit of that, just acknowledging that the survey process is still ongoing. There are still many questions that we have, and that this is all a learning experience as we go along. But we just wanted to start to share some of those things. We wanted to look at Canada and the United States Indigenous populations together for a couple of reasons. One of the focuses of this conference, the Metropolis conference this year, is this notion of borders. And we wanted to talk about borders in a couple of different ways. Certainly the nation state borders that are imposed, so the border in this instance between the US and Canada, but also think about the borders of Indigenous nations as they're embedded in geographies that are overlapping and shared with other populations. So we're going to talk about those issues just in terms of the survey data and in terms of some of the policy outcomes as we go along. So we thought that the conversation around borders would lead to some interesting comparisons and contrasts between the United States and Canada Indigenous peoples populations. We also wanted to point out that more so than by comparison to Mexico, Indigenous nations and peoples in Canada and the United States have similar political rights and face similar social and economic circumstances. So trying to understand how in the face of those similarities, there might still be differences in the impacts and resilience in response to COVID-19 are really interesting questions. We're going to look at, amongst all the different kinds of data in the survey, at just 3 different things today to try to be quick, to try to just give you a taste of some of the kinds of things that we're finding and raise some of the questions of interest. We're going to look a little bit at mental and physical health self-assessment by self-identified Indigenous people. We're going to look a little bit about vaccine hesitancy and vaccine uptake. and we're going to talk a bit about trust in institutions. And then we're going to conclude with some comments about borders and some other specific observations about policy in Indigenous nations and policies of Canada and the United States toward Indigenous people. So here's your first taste of some of the kinds of data that we've been gathering through the survey. The survey basically asked the question of, since the beginning of the COVID-19 crisis, how would you rate your mental health? I think there's some really interesting differences coming out here. I want to draw your attention first to the US perspective, which is the bright red bars in each of these sets of data. On the left, we've got individuals who are responding that their mental health has been excellent or very good during the COVID-19 crisis. And on the right, we've got individuals who are assessing that their mental health has been bad or very bad. So here you can see by comparison to non-Indigenous Americans. So in both charts, that sort of lightest kind of greeny gray color is the non-Indigenous, both Canadians and Americans, depending on the country you're looking at. You can see that oddly, Indigenous people responding to the survey said that on average, more of them said that they were experiencing good or excellent mental health, and more of them on average were saying that they were experiencing worse mental health. I kind of call this a barbell effect. You don't have very many Indigenous people answering that middle answer, which is, oh, my mental health has been good. Instead, you've got a relatively large number saying excellent or good, and a larger number saying bad or very bad, than by comparison to the mainstream non-Indigenous population. Kiera, what's been going on in Canada with regard to the answers to this question?
I think that we see some of the same barbelling effect, but not to the extreme as in the U.S. But what's really fascinating for me is really, I want to raise a couple points. One, we know that these surveys were definitively done before Kamloops and Gauss unearthed or confirmed, because there was no discovery, but confirmed the massive internments of children from their residential schools. So we know that the data was collected before that. But what's interesting is I didn't really expect the mental health data to be this good amongst Indigenous people. And I think that the difference here between Indigenous people and Canadians is really, especially between First Nations and Canadians, or First Nations people with status, the black bar, and the lighter gray bar representing Métis, or the very light bar representing non-Indigenous people, is also one of that can be explained by community, but it can also be explained in reference to programming and really government-focused programming on First Nations people. So I think that we've seen better mental health outcomes, at least reported better mental health outcomes, because community showed up, and because many First Nations peoples, as well as many Métis people and non-status people, have this really poignant connection to community and a community around them. And I think we see the same in the US. But what's fascinating is that community went online, and that community has followed and continued to develop and to continue to be there. So we've seen online powwows, we've seen the Bear Clan in Winnipeg, as well as throughout Manitoba, going door to door to check on relatives and to check on elders. And really this development of both an online community as well as community picking up both in urban context and in on reserves.
So Kiera, I think that is really interesting. You're saying that if we look at those Canada bars in the left-hand graph, that excellent or very good one, and say, all those, the dark black to the lighter grays to the left, that's all First Nation status, First Nations non-status, and First Nation, and then Métis. If we really combined all those on average, there's not that much difference in the way that people were viewing their mental health on the upside, right? And you're saying, despite the fact that we might have walked into this expecting that First Nations people would have been saying their mental health was terrible or worse or bad, we're seeing some really similar answers. And you're saying that's because community stepped up.
Absolutely. And do you think that's the same in the US? Like, have we seen community step up in the US?
Absolutely. We absolutely have. And I think that's actually one of the reasons why you're getting that red bar, which is Indigenous population, the Native American population, saying a larger proportion of them actually saying their mental health has been very good, is because there's been community there to rally around them. I think the other thing that jumps out at me, and I'd love your comment on this as well, is that that's kind of on the good side. We've sort of seen the positive nature of Indigenous community working on behalf of their own members to really uphold them and give them strength and confidence even during this crisis. The thing that we can do in Canada that we can't do in the US is really pull apart the population. So the US numbers, the N here is not as big as we'd really like it to be. So even though we looked at American Indians, Alaska Natives, and Native Hawaiians, which those of you who know the Indigenous population breakdowns in these states know that those are the three relevant categories. In Canada, there's enough response to this survey to sort of understand on the downside here, the differences in answers between status First Nations people, non-status First Nations people, and Métis. And Kiera, the thing that stands out to me is that 35.1% of non-status First Nations people saying that they had very bad mental health. What's going on there, do you think? What would you posit?
I think that it's very different here than also in the US. In the US, you have a lot of services for urban Indians or urban Indigenous people that we haven't seen develop to the same extent here that are federally funded services. So I would think that in the case of First Nations, status First Nations, we still see a lot of services being moved their way. We've seen vaccine rollouts that have absolutely been focused on a status First Nations, so status Indians under the Indian Act. And the Métis have been left out in most provinces of that. Manitoba, until early April or mid-April, absolutely denied that Métis were any more affected by the pandemic than were non-Indigenous people, and so continued to deny more specialized services such as vaccine clinics to Métis. So I think that this denial of service and not being included in some of the service rollout really affected mental health. When you don't know when you're going to get your vaccine and you're being denied service delivery, even though you're an Indigenous person and you are a federal responsibility, when you see this being played around and really identity politics being played by the state, I think that's really affected people's mental health.
Wow, I think that's really interesting. And I think it's worth us plumbing that more as we look at future survey information. And I'm really hoping that in future rounds, we'll have enough information to start to understand some similar differences in the US setting. Kiera, if with your permission, I'm going to skip the next slide on physical health and go straight to the discussion about trust in institutions, just because I think we've got a lot to say about each side. And this one strikes me as really a nice follow-on to what you were just talking about. You know, Kiera's raised this point about in Canada, there are these borders created by policy, right? A border between who counts as a status Indian, who's a non-status, or who counts as a status First Nations person, who's a non-status First Nations person, who's a Métis person, and that those have generated different levels of trust in institutions, or at least this degree of mental health concern that might be evidenced in trust. We don't have the same breakdown here by self-identified population. Here, this is using some of the ethnicity type measures. So this is an issue we're still trying to work out within the data, that we have kind of two ways of identifying Indigenous population, of an ethnicity declaration or a self-identified Indigenous declaration. But Kiera's points do raise this point around trust. And you can look at either the right-hand set of columns or that middle set of columns. They're really just mirror images of each other. The do not trust is the mirror image of the trust column. So you can see that in Canada, 63 and 37 add to 100% in that first row. So really, however you want to think about it. I'm going to concentrate really on the second and third column of trust in Canada and the US. I think what's super interesting in the US is that we see that there's really similar trust in city and municipal authorities and provincial and state governments, realizing that the N here is very low. We're only looking at 60 survey responses. We've got a really healthy 282 survey responses in Canada. So those numbers are more, we can have greater confidence in those numbers. But we do see an interesting little kick downward when it comes to, do Indigenous peoples responding to the survey say that they trust the federal government? And we see a 5 percentage point drop off between the city and municipal and state and provincial governments and the federal government. Just much less trust, or at least a little less trust, in the federal government in the US amongst Indigenous people, which is not surprising. I think the big difference here is this jump then that there's a lot of trust in public health officials. You might say, oh, there's a big jump to that tribal government too, but remember there's only an N of 33 there. So that's something we want to keep our eye on, is our tribal governments viewed in the crisis as much more responsive and trustworthy than these other non-Indigenous settler state colonial governments are. We would anticipate that they would be, and it'd be interesting and great to see the survey evidence suggesting that, or to plumb why people don't think so if it turns out differently. But right now, I just don't think we have enough data. But the big win is that people do seem to really have a lot of confidence in and trust in public health officials amongst Indigenous people in the United States. Kiera, do you want to comment on sort of those somewhat similar findings in Canada?
I think it's really quite interesting on how, I expected that there would be less trust towards provincial and municipal governments. We're seeing that really across multiple jurisdictions for non-Indigenous people, that for, at least in parts of the survey, an increase in trust towards the federal government. And it's interesting that some provinces have maintained a higher, have increased their level of trust in the last year and a half, but provinces like Manitoba and Alberta have gone down. But 61% still across the board is a very high number for
really
people trusting a non-Indigenous government, particularly a non-Indigenous government that have at times really tried to maintain their numbers or their populations getting the vaccine and healthcare and a rollout vis-a-vis federally funded Indigenous healthcare authorities or federally funded Indigenous people. And so there's been this interplay that's interesting. So it's really interesting to me that provincial governments, which we usually throw away in terms of Indigenous politics, this is a really interesting thing, and it's something that I'd like to look back on and maybe do some work on this issue of trust, because it is really fascinating. I expected numbers like the US. So, but it's also fascinating that right now we're sitting at a time, I look at the US numbers and I think, oh, is that a Trump effect still? But it's interesting because Biden is actually polling way better than our prime minister in Indigenous communities and elsewhere. So I also look, why is the US so low in comparison? And have these numbers shifted over time? Is this the type of number that you expected, Miriam?
It is kind of what I expected, but you do make me think that the future surveys are going to be very interesting to see if this number rises because of the, as everyone knows, the very dramatic change in administration and the eroded trust in government. But of course, there's the long-lasting lack of trust in the federal government in both countries amongst Indigenous peoples. And there are other factors that, of course, could cause this to fall even more. You raised the boarding schools findings effects on mental health, whereas our new Secretary of the Interior, Deborah Haaland, who, as everyone knows, is a Laguna woman, has just introduced our own commission here. So that could really decrease trust in the federal government, completely absent anything that has to do with COVID-19. I do want to go on to this next slide, though.
Yeah. I want to go, if we could go back for just 1 minute. I want to just make note on public health. And I think that public health officials have become the superstars of the pandemic. And in Canada, where I think that this 10-point or 11-point difference really comes into play is that both the federal government and the provincial government in multiple jurisdictions have engaged Indigenous people in high public health official roles. So we have people like Evan Adams that has been seconded from BC over to the feds. We have Marsha Anderson that is on the news continuously in Manitoba. That's a U of M professor that's sitting on as a lead for Manitoba First Nations pandemic response coordination team and is working with the province hand in hand. And I think that that has had a real huge effect on trust in public health officials. And I think that that also speaks to community and this development of community outside reserves and outside band governments and into these public roles. And I think that that's been really meaningful in Canada.
Oh, I'm so glad that you pulled me back to say that, because I think that is a true difference between what we've seen in the United States and Canada. So thanks for adding that. I want to go on really briefly to talk a little bit about vaccine hesitancy, and this is something we're going to continue to track. It's a story we keep hearing in the United States. It's a story of great difference we're starting to understand between different Indigenous communities as well. There was a big piece in the New York Times in March reminding folks of how much vaccine hesitancy there is amongst some of our larger Native populations located more in the southern parts of the United States, like the Cherokee Nation has been really struggling with vaccine hesitancy. Whereas on the other hand, there are communities like Navajo and some of the Pueblo communities that have some of the highest vaccination rates in the US, if you look at separate communities. So I wanted to first draw attention to some of these places where the bars are high. Like, what are some of the reasons that Indigenous communities in both Canada and the United States are saying that they're hesitant to take vaccines? So those are things like the too rushed, it's new, there's side effects they're worried about, COVID vaccine trust and ingredient concerns, and just personal preference. Just looking at these bars, those are where the highest bars are. I don't know, Kiera, if you want to comment on what some of these reasons, the high bars, those high black columns in Canada.
I think that both for the COVID vaccine trust ingredients, trust and then the ingredient concerns, as well as the too rushed, both of those speak very broadly to this issue of history and this history of Indigenous people having been used as guinea pigs in healthcare experiments in residential schools. And this is brought up on a previous panel that I just jumped off of. And I think that that is a really big concern for especially older people or those people that have learned stories or heard stories coming out of residential schools. I think that those are really big concerns that are driving. So I think that if we were to try and track this in future, or ask those people that haven't been vaccinated or just got one vaccine, we might find a different story amongst Indigenous people, perhaps on both sides of the border, because I don't think that this is a Canada issue. I think that those same sorts of experiments were going on not only amongst African Americans, but were also very much going on in boarding schools and residential schools in the States.
Yeah.
So,
yeah, it almost makes me think that there isn't quite the right question being asked here about why there might be hesitancy. I wanted to point out one other thing here, and these arrows are now going to some very different places. Looking at the too rushed one, the personal preference, and the anti-vax. The reason I drew these arrows is because these are the places where you're seeing the biggest difference. You've just pointed out something that it could be a similarity between the Indigenous peoples in Canada and the US in terms of these historical experiences with institutions and being, guinea pigs and being tested upon and things like that. But here we're also starting to see some really different attitudinal differences between the two populations. In Canada, like, this really big reason why is this too rushed and the too new and the side effects issue. But we see some big differences in vaccine hesitancy in terms of personal preference and anti-vax attitudes. Those are really low reasons why people won't get the vaccine in Canada, but there's a healthy difference there, that these are, kind of popular-ish reasons in the US, and significantly more people in the Indigenous people in the US are saying those are reasons they won't get the vaccine. And in fact, if you combine that personal preference, which is, I look at that as this whole sort of, it's my right to not get a vaccine idea with anti-vax, you'd be right up there with a red bar that is as high as that 28.4% on the too new thing.
And I wonder if that's also about media in the US.
Sure.
That we don't have as far right in mainstream media as Fox News. That's not something that's readily available on satellite TV or on APTN or CBC and so I wonder if that also has to do with news media, but also I think maybe has to do with leadership and community leadership, and this. I think that so much of this data is sometimes really escapes over or ignores some real regional difference in some of the borders within our countries. So the borders between reserves and the borders in regions, and you had spoken to that, and I think that might also be really huge on if we could map this regionally, looking at some of the more conservative or some of the more religious, traditionally First Nations communities in the U.S. as well as in Canada. So I'm really now interested and think that we really do have to ask some different questions. And this has been a fascinating thing that Avery and I have had many conversations on. So I think we need to dive into this in the qualitative work. Do you have any other things to say on this?
I don't. I'm conscious of time though, Kiera, and we've burned 30 minutes at this point. Do you want to add a couple things with your last slides?
I just want to acknowledge on the next slide. Can't believe it's been 30 minutes. You have conversations between friends and it goes this long.
Sorry if I can interrupt you guys quickly. You can take some more time if you like. We are waiting for our other presenters, so there's no rush for you to finish.
Okay. One of the things that I wanted to just note is on vaccine uptake, and I really wanted to pay attention, as Miriam had noted, that the vaccine, some of the vaccine questions really mask huge differences in the country. And Manitoba, and I just took this because it was some easy stats to get a hold of. Manitoba, as well as all other jurisdictions in Canada, are able to pull out First Nation data with moments notice, because it's a federal number, it's a FNIB number, the First Nations Indigenous Health Branch, versus a provincially funded healthcare system. And so they do it for billing purposes, and so it's very easy to get them to pull different stats. And it's really fascinating to see that on reserve, First Nations have far exceeded vaccination rates, especially on second dose. So we're really seeing a great uptake. Off reserve, where we haven't seen as widespread of an uptake, because of course this was excluding Inuit, non-status, and Métis from early access to vaccines. We still have 54%, which is 20 points lower than the national or than the provincial average, but we have a higher rate of second dosing. So this is something that we're going to really want to pay attention to. And that we have different data across the country. We have different data even in communities in Manitoba. I'm sure that we could take a look on a map and find a community that has 80 or 90% on the first vaccine and are very much getting up there on the second vaccine. So we have to pay attention to these regional borders. And one of the borders that has most touched us, I think, as researchers, is that international border. And that international border, I'll just go to the next slide, has been very much in the news, and this is close to where I grew up, so it's very much part of my understanding in the world. And to get out of a Manitoba context into the Blackfoot context, or Siksikawa, or Nitsitapi, the border runs through so many of our territories. Akwesasne, you have the Canada-US border running straight through the reserve. That border actually hasn't been shut to citizens of Akwesasne. But Ontario, Quebec, and New York borders run through that. And you've had people that have been unable to go between the Ontario and Quebec side of the reserve, but they've been able to go from the US to Canada sides of the reserve. Blackfoot territory, it doesn't run through the reserve, but it runs straight through Blackfoot territory. And what's interesting is the Blackfeet Reserve in Montana claimed to have had a 98% vaccination rate amongst citizens over the age of 18 by April 2nd or 3rd. I did not write the date in here. Pardon me, it says mid-April. I did not write the date that this article. So what they did is they looked north to other members of their confederacy, and they immediately opened vaccine clinics right on the Canada-US border. So they held 4 days of this vaccine clinic. You could drive down to the border, drive into the US, do a loop, get your vaccine, and drive back into Canada. This happened for 4 days. First 2 days were for Confederacy members only. The next 2, they had a 3-kilometer line traffic jam to get to the border and turned thousands of people away that were simply trying to get down for a vaccine. This was magnificent because it allowed community members to see each other. And I looked and looked and looked, and we have yet to find any examples of the border between the US and Mexico being opened. But this has been a real big issue, I know, for so many families, with families on both sides of the border. This has hit our research team. And I think that when we think about the border, we have to also think that this border is a trajectory that was created by the federal governments and their predecessors, and that not only borders between reserve and off reserve matter, but this border between that has been railroaded through communities also matters. So, Miriam, anything to say on this? I just thought that this was such an amazing story. And then
I think that this, I would just said no, but then I do have something to add, which is in many ways, this circles back as a story that reinforces what our conjecture about our very first slide about mental health, is how much these community sort of kicking in to take care of one another is something that can bolster, in this instance, physical health, but also mental health. And so you really see that I think this reinforces that idea that the reliance on community is something that increases the possibility for better physical and mental health. And this story just underscores that.
Yeah. And it's the border here, this real story about mental health is such a fantastic story to think about in Blackfoot territory, where the border has always been this place of animosity, this place of this middle zone where Blackfoot have to follow these colonial laws in their own territory. And there's a story by Thomas King that was made into a short movie called The Border, or Borders. And look at it, because it really does speak of a very different reality, but that border being opened and used to recreate community and for community to get together on these 4 days was just really amazing. And people spoke so much of this, and community wanted to continue it, and we're taking away from second shots, but were willing to take away from second shots to really help not their neighbors to the south or to the north Canadians, but their cousins, their relatives, and their
family.
Their family. So those elders. So thank you.
Yeah.
I'll leave it there.
Thank you everyone for this opportunity to muse on some of the things that are coming out of the data. And we really welcome hearing more from your questions.
Yeah.
So we have no questions right now. If any attendees have questions for the presenters, they can put those in the Q&A section, or they can message us directly in the chat. It's not a question, but we have a comment here from Avery Halberg. Just for your information, I pulled out the data. I ran Fox News was the most watched news source for Indigenous people in the US.
Wow.
Yeah, thanks for pulling that, Avery. And I think that we're really starting to see some of that in some of the Midwestern and Southern Indigenous communities in the US. So on one hand, I was very excited to hear in late March, early April, that the Cherokee Nation, even ahead of the state of Oklahoma and some of the other Indigenous nations, although I do think that Chickasaw and or Choctaw was shortly after that, opened the doors to say any Oklahoman and any other Native person could get a vaccine from their clinic. So we were like, this is great, that they're so sharing, so wonderful. But when you look beneath the surface of that, that was because they were already in that late March period fighting up against the vaccine hesitancy that is reinforced by the political messages coming through on places like Fox News. And so in places where there is better communication, or different communication, that I think that we've got some higher vaccine uptake. It does tell us, and this is part of the broader conversation in the United States as well, that there have to be very specialized messages by communities. And whether or not those are communities of color, whether or not they're Indigenous communities, whether or not they're more conservative communities, those messages do need to be tailored to those places. And so I think that really figuring out what's going to work to convince kind of oftentimes sort of a younger Indigenous population that may feel less vulnerable than some of their elders. Like that, I think that's the real challenge in certain parts of Indigenous country now.
I think we've seen some of the same issues, and we've seen numerous communities give their extra vaccines to towns around them, to healthcare workers, to teachers and the like, to police officers even. But what's been fascinating in those stories is the crackdown by the province of Manitoba and other jurisdictions to say you're not following health orders, you're not following vaccine rollouts, you can't do that, we're going to eliminate your extra vaccines. But it also speaks to this issue of vaccine hesitancy, that if 25% of the doses are available in a community, that's 25% of the community that isn't getting them. And as we know, the Indigenous communities are still in Ontario and Manitoba and elsewhere the highest rates of COVID in the country. So that really does speak to the reality of we need to get this, and we need to get different messaging out to communities. And that's going to be really difficult to overcome some of those historical issues.
Just an update, it does look like our other presenter is going to be able to join fairly soon. I'm just following what's going on in the presenter chat just to let others know. So there will be a Mexico presentation soon. I don't know, one of the things I wanted to just comment on that I'm looking forward to from future rounds of the data that this conversation about communication is getting us toward is I'd really like us to get that data on Indigenous populations, Indigenous people in Canada and in the US in terms of the trust that they have in their band government and their band leaders and their tribal government and tribal leaders, to just get the numbers on that up and get some cleaner data so that we can understand whether or not those are important entities, and also continue to plumb this issue around public health officials in terms of their ability to communicate about vaccines and inoculation health and things like that. So I think that there's some other data that we're kind of waiting on and looking forward to next waves of the survey for that information that are going to inform us more about how to communicate well with different subpopulations.
And as we're just waiting for Rolando, I see that there's conversations and he's trying to get on here. But as we continue through to the third and further waves of this survey, if people have ideas for questions, please contact us. We're reachable on Twitter. We're reachable. We have the COVID Impacts website, covidimpacts.ca. We're reachable through multiple academics. We have a COVID Impacts at Manitoba account. You can email me directly, and we're really interested in moving different questions and really asking the right questions for further rounds of the survey. And I think we have Rolando. And I'm simply going to pass it over to Rolando.
Hello, everybody. And I prefer speaking Spanish, and we need a traductor because my English is a few so.
Yes, Rolando, I'm here to help you in any way you need for the translations.
Yes, of course. Thank you. And Ángel is in this reunion. Bueno. Good afternoon. I guess the team of indigenous people in Mexico, and I become in Spanish. Vamos a presentar los datos que tenemos actualmente sobre la investigación que hicimos en México, en las regiones indígenas. Los presentadores somos el doctor Ángel Vicente Ferrer y un servidor. Muchas gracias por su atención y continuamos. Lo que vamos a presentar en primer lugar es una breve numeralia acerca de los efectos de la enfermedad en la región de Latinoamérica. Son datos retomados del diario El País, un diario español que a su vez los toma de una institución que se llama John Anthony Hopkins. Entonces aquí lo que vemos es que México es de los países que tiene menor afectación en cuanto al COVID. Vemos que hasta abajo, junto con El Salvador, es de los que menos impactos tiene. Vemos que las campañas de vacunación han avanzado relativamente rápido y entramos directamente al tema. México es el país de América que tiene mayor población indígena, con alrededor de 25 millones de personas que se identifican como indígenas. También tenemos que más de 2 millones se identifican como afromexicanos. Estos son nuestros dos puntos focales de interés. Aquí vemos cómo ha avanzado el tema del COVID en la población indígena en México. Quiero llamar la atención sobre el dato de que Chiapas es el estado que tiene mayor población hablante de lengua indígena. Sin embargo, es uno de los estados que menos afectación tiene, y Yucatán, que es el tercer estado en cuanto a población hablante de lengua indígena, es el que tiene más afectación. La Ciudad de México, que es una ciudad importante en cuanto a población indígena, aparece en segundo lugar, y ahorita voy a dar un poco más de datos. En cuanto a los municipios indígenas, encontramos que son 163 a nivel nacional, y que de ellos en el 89.4% Ha habido casos de COVID. Valladolid, en Yucatán, es el municipio indígena que más casos ha presentado de contagio, mientras que Papantla, en Veracruz, es el municipio indígena donde más muertos ha habido por el tema del COVID. Nuestra investigación se va a centrar en estos estados: el estado de Nayarit, el estado de Michoacán, el estado de Puebla, la Ciudad de México y el estado de Oaxaca, donde tenemos 3 equipos, y ahorita explicaré por qué es esto. En cuanto a la población hablante de lengua indígena que abarcaríamos en esta muestra, estamos hablando de que representan el 30% más o menos del total de hablantes de lengua indígena. Tenemos a la lengua náhuatl, que es la lengua más hablada en México, y tenemos al mixteco, que es la tercera lengua más hablada. Las otras lenguas tienen población media, y un dato importante es que estas 7 lenguas las hablan los miembros del equipo, y por ello las interacciones proponemos que van a ser en lengua indígena. Estos son los...
Te voy a interrumpir un segundo. No tenemos traducción en vivo, entonces tendrías que hablar parte de la presentación para yo poder traducirla. Y así todos nos vamos entendiendo. Entonces, si quieres, desde ahorita, haz una parte de la presentación y yo la puedo traducir.
Muy
y
bien.
así vamos entre...
Muy bien, muchas gracias. Muy bien. Esta es la muestra, son los lugares en donde vamos a trabajar. Ahí tenemos la población indígena, la lengua, y aquí lo que quiero destacar es que la mayoría de nuestra muestra pues está en comunidades rurales. Tenemos un número importante en ciudad, básicamente la Ciudad de México y el área conurbada de la Ciudad de Oaxaca.
These are the places that we are currently, that Mexico is currently working in with the indigenous populations, and these are the sample population that they're having the results and their questions on.
La Ciudad de México, como lo había dicho anteriormente, es la ciudad que tiene mayor población indígena en el país. Son más de 300,000 personas las que se autoadscriben como indígena en la Ciudad de México. Porcentualmente, la Ciudad de Oaxaca es la que tiene mayor porcentaje, con un 40% que se autoadscriben como indígenas, y también es el estado que tiene mayor población autoadscrita como indígena, con el 65%. Bien, aquí estoy mostrando cómo ha afectado este tema en las poblaciones, y hay 2 grandes grupos: la población urbana, netamente, que abarca la alcaldía de Tlalpan en la Ciudad de México, y San Pedro Ixtlahuaca, un municipio conurbado a la Ciudad de Oaxaca. En medio tenemos a la comunidad de Santa Fe, que podría ser vista como un pueblo grande o como una ciudad pequeña. Y abajo tenemos a las localidades rurales. Lo que vemos es que donde ha habido afectaciones son en las áreas urbanas, mientras que en las áreas rurales lo que tenemos son 0 contagios y 0 defunciones.
Urban places have been the most affected by COVID instead of rural. If you look at rural places, there have been 0 contagious or of the COVID disease. Of the COVID, yeah.
Bueno, esta es nuestra muestra. Tenemos grupos focales en las ciudades que abarcan familias, 2 familias, una en la alcaldía de Tlalpan, que es la familia García, y una en el municipio conurbado de San Pedro Ixtlahuaca, que es la familia Valles. En Santa Fe, bueno, vamos a hacer el grupo focal con la comunidad, y las otras todas son a nivel comunidad. Bien, lo que encontramos en esta familia en la alcaldía Tlalpan es que no hay casos de COVID. Sin embargo, su situación económica ha sido afectada por este tema, lo mismo que en el caso de la familia Valles del municipio de San Pedro Ixtlahuaca. Por lo tanto, en el caso de la familia Valles, ellos se han dedicado a poner un micronegocio mientras que la familia García, que se dedicaba al comercio de pollo, ahora ha instaurado nuevos métodos para la venta, como es el servicio a domicilio. Y lo que vemos en ambos casos es que a nivel psicológico ha habido problemas de estrés, depresión, ansiedad e irritabilidad, sobre todo entre los jóvenes. En el caso de la comunidad de Santa Fe, es una comunidad que fue severamente afectada porque su economía se basaba en la venta de productos de barro a nivel nacional. Entonces el encierro provoca que ya no puedan salir a vender a nivel nacional y por lo tanto, de ser comerciantes independientes, se vuelven jornaleros agrícolas. Los contagios en esta comunidad se han dado principalmente en los campos de cultivo y en las fiestas que se siguieron haciendo en la comunidad, sobre todo en el mes de enero. Algo interesante en el caso de esta comunidad y en la de las demás que vamos a ver es que las autoridades comunitarias son altamente valoradas y respetadas. Por lo tanto, pudieron tomar medidas como establecer un control de precios de productos básicos y una intensa campaña de comunicación por medio de la radio comunitaria. En el caso de las otras comunidades donde son netamente rurales y que no sufrieron efectos del COVID, lo que vemos es, en primer lugar, que ellos recurren como método preventivo a la medicina tradicional y para protegerse de las enfermedades frías, porque el COVID es concebido como una enfermedad fría. Restringen el acceso a las comunidades, durante un tiempo no se deja entrar a gente que no es de la comunidad, y las autoridades comunitarias acuden a métodos de reequilibrio como es el ayuno para solicitar la protección de las deidades y de los antepasados. Acuden también al consejo de los mayores para minimizar los riesgos de la pandemia y también hay una campaña en las diferentes lenguas. Bueno, aquí vemos dos.
Sorry, Rolando, ¿puedes ir una atrás para que resuma? Perfecto. Hi, good afternoon, everybody. Chris asked me to step in instead of Majo, so I can make a short summary of each of the slides that Rolando is presenting. Fortunately, all the slides are in English, so I'm sure you have been able to follow the information. Rolando here presents each of the communities, each of the places and cases of our focal groups, and he more or less present some of the situations. For example, in Tlalpan, Alcaldía Tlalpan, which is the first line that you're seeing, we're talking about an urban context. It is within Mexico City, so people have to adjust a lot of their business, a lot of their activities every now and then. And then he went through the rest of the cases where are now in a rural context. So San Pedro, Quiroga, Jocotepec, San Lorenzo are different places, small communities, most of them. And he said that it hasn't been extremely risky, the situation, but eventually there were some contagious people, and as well, people have to adapt their activities, especially their economic activities, and but most of them, especially on the lower side of your screen, people approach to traditional medicine, used to traditionally protect from cold disease. The access to communities was very restricted, and the communal authorities act accordingly. And well, little by little, there were much more awareness from these native people, and especially they started a campaign in different languages. Listo, Rolando. Gracias. Tienes el micrófono apagado, Rolando.
Gracias. Voy a presentar dos ejemplos pequeños de las campañas que se hicieron a nivel nacional en lengua indígena. El primero es en lengua nayari, que se habla en Nayarit.
Creo que no se oye, por lo menos yo no lo oigo.
Akita kenaye kaniri.
Apa auta kachi H.
Estos fueron los mensajes que se estuvieron compartiendo por medio de las radios comunitarias y por medio de trípticos en los centros de salud en las distintas comunidades.
So as you know, there is not a lot of written communication for many of these languages. So a lot of oral messages were used through the radio, through different media. And these are a couple of examples in Nayari or Cora and Huichol or Wirrárica.
Gracias, Mario. Bueno, finalmente, pues lo que tenemos es que al ser miembros de las comunidades, tuvimos la oportunidad de acceder a ciertos espacios que de otra manera nos hubiera sido más difícil. Vemos que las comunidades rurales sufrieron impactos muy pequeños y en las áreas urbanas, a pesar de que en el contexto había muchos contagios, pues en los grupos focales con los que trabajamos no se presentaron tampoco casos. Vemos que en las comunidades indígenas se recurre a las estrategias tradicionales de protección, como son el apoyo mutuo, como son las redes paisanales, a los remedios tradicionales, a los rezos y en este caso también a los ayunos. Hubo afectación económica y psicológica, vemos impacto sobre todo entre la gente joven en cuanto a la irritabilidad, el estrés, la depresión, etcétera. Y algo que nos mencionaba la gente y que aún no tenemos oportunidad de comprobar es el efecto que tuvo el tipo de alimentación que tienen. Ellos nos decían que consideraban que el maíz era uno de los factores importantes por los cuales no había habido tantos contagios y el hecho de que la interacción social continuó a pesar de la pandemia.
Okay, so I'm going to basically read the conclusions since it's the last slide. Rolando said that at the beginning of the project, there was a little bit of delay because of this context and because of different factors. But since Rolando, Ángel, and other members of the community have direct contact with the communities themselves, they have been able to gather a lot of material. It is important for us to say that fortunately, rural indigenous communities have not been severely impacted. Indigenous groups suffered few infections, obviously, but even in few urban areas, but there hasn't been such a tremendously amount of diseases that at some point we could have thought about. In order to face COVID and its impacts, indigenous groups resorted to their traditional strengths mainly, that is community and hometown networks, fasting, prevention through traditional remedies, as well as prayer. However, the economic and psychological impacts were severe, including irritation, stress, depression, especially among the young. And the project, we are still working on the impact on nutrition specifically and the responses in terms of social interactions. Mr. Rolando.
Queremos agradecer el que nos hayan escuchado en las diferentes lenguas del equipo. Dios me amui, Kazocamati, Dios Cujuy, Pamparios, Nandibe, Timana. Y damos finalmente un saludo solidario a nuestros hermanos canadienses debido a los recuerdos tan dolorosos que en estos días están teniendo. Muchísimas gracias.
And well, we finally finished the presentation. Thank you for your attention, for all this organization. We apologize for these digital confusions. Thanks very much, Majo, for starting the translation. And thank you all for your patience. In this last slide, we thank you in different languages. Thank you, muchas gracias en español, Dios y Meyamu en Purépecha, Tlazocamati in Nahuatl, and other languages. We also want to send our solidarity to the Canadian brothers, the native people, for the painful memories that we share. And thank you very much. Merci tout le monde. Muchas gracias.
Muted. Were there other questions in chat?
There are no questions right now.
Okay. I'm just gonna, if no one has any questions, what an amazing panel. Thank you for the translation and for your presentation, Rolando. That was fantastic. It was such an honor and such a privilege for me to have a public conversation with Miriam and to be doing this. It's always a privilege to be sitting with her, and wonderful to be doing this work. And if people have ideas, as I've said, please continue to reach out, and we will continue to try and push this research forward. As we know, it's ongoing in 3 countries, so we could leave it there. So thank you very much. And I think that this is the last panel of the day. Am I right on that?
Yeah, that's correct.
Okay. So everyone have a great afternoon, if there is nothing else. And we will see you back tomorrow. And thank you to the panelists.